Okay, so you're working a shift in the emergency department when an ambulance screams up to the department and drops off a patient who's complaining of chest pain. The paramedics drop the patient off into your able hands, and then they take off. The triage nurse greets the patient and grabs a quick set of vital signs and hands this information over to you. The patient doesn't look good. He is sweaty and uncomfortable looking. So you recognize this guy doesn't look well, so the first thing you scream out is, can you please place this patient on an IV, O2, and monitor? So the nurses do that. The monitor shows sinus tach at about 140. Remembering that this guy's main complaint was chest pain, you quickly order an EKG as well, which is done and handed to you quickly. Taking a look, you notice ST elevations in these leads over here. These are the high lateral leads, which then gets you thinking, uh-oh, this could be an ST elevation MI. And at the same time, you are also assessing your patient's primary survey, the ABCs. Your patient is awake, he's talking to you, he's moving air in and out well. So you think the airway is okay. Next, he's breathing, he's moving his chest, his pulse oximetry reads 98%. His breathing is also okay. And his circulation, he is not hypotensive. And while he is hypertensive and tachycardic, you realize his circulation is not going to kill him immediately. And so, as for now, you're saying his circulation is okay. So you have judged his primary survey to be intact. Time is of the essence, so you do a quick history and physical. And the patient tells you he's a 57-year-old man, and he says, I've been having chest pain that started this morning. It started in the middle of my chest, and it feels like my chest is on fire, like something is tearing through my chest. It goes to my back, and it goes down my back. Exertion doesn't seem to make it worse. Breathing doesn't make it worse. No fever, no cough. He's never had pain like this before. He is a hypertensive diabetic. On his exam, he looks horrible. He's sweaty, he's diaphoretic, but he's awake and talking to you. He looks very uncomfortable. You hear clear lung sounds, normal heart sounds, normal bowel sounds, good blood pressures and pulses on both sides, and they are symmetric. Now, you got this STEMI diagnosis just looking you in the face, but you know that you need to have a broad differential. So you say chest pain. What is going to kill a person who presents with chest pain? And you make a list, and of course STEMI or other acute coronary syndromes are there at the top, but you also have thoracic aortic dissection, PE, pneumothorax, esophageal rupture, and pneumonia. The radiology tech comes by to do a chest x-ray, which you normally do with your patients who have chest pain, and you get the x-ray, he lets you look at it on the screen there, and you notice, whoa, hold on a sec. That is one huge looking mediastinum. So you're starting to go through your differential, and you think STEMI is certainly on there because look at that, we have that here. But thoracic aortic dissection, you're worried about that too. PE, it's possible. Pneumothorax, you don't see it. Esophageal rupture and pneumonia really don't seem consistent with what you have so far. So you say, before you send this guy to the cath lab, let's get a quick CT of the chest. And on the CT of the chest, you see this here with this double lumen here in the ascending aorta. So now you're thinking, that really makes me think thoracic aortic dissection. So that's our working diagnosis now. So what are we going to do? We need to start initiating treatment. And you know there's 3 things you need to do. Number 1, you need to lower this heart rate. Number 2, you need to lower this blood pressure. Number 3, you need to call a surgeon. So your clerk calls up the surgeon, Dr. Cutter, and you tell him that you've got a patient here with a ascending thoracic aortic dissection. He says, great, get that guy stabilized and get him up to the OR. I'll be waiting for you. He then hangs up. And then you say, well, let's lower that heart rate. So you order up an esmolol drip, which is a selective beta drop blocker, and that drops the heart rate down to 70, which is great, but the pressure's still high. So next, you order something to lower the blood pressure, and you order up some nicardipine. And now you get the pressure down to 90/70. You call up the surgeon, and he's ready. You type and cross this guy for 4 units and send off a bunch of labs, and he goes off to the OR. And now you're left standing there to get your next patient. A 3-year-old who's running around like crazy with a runny nose and cough. So welcome to emergency medicine. Over the next month, we're going to talk about that whole process that just went on there and get you somewhat proficient in doing some of that. So, welcome.